Hi, welcome. I want to welcome all of our participants to the webinar on COVID-19 and cities. I'm Gina Lovasi, and I am co-director of the Urban Health Collaborative at Drexel University's Dornsife School of Public Health. I'll be moderating today's panel. Urban scenes usually are bustling with people, but they've been dramatically altered in the last month. And on city streets around the world, people have become scarce and can be seen separated apart from each other, clad in masks and in gloves. And as we'll have a chance to discuss today, governments and residents are facing both the loss of lives and livelihoods due to the COVID-19 pandemic. Yet the experience has not been the same across all cities, and we'll have a chance to think as well about signs of innovation and compassion and action that's protecting health in cities, as well as discussing how cities differ in their vulnerability. Both of our panelists are extremely well poised to speak about COVID-19 in cities, and so I want to start by welcoming them. We'll then have a chance for each of them to give some comments and spend a good portion of our time together addressing questions. So I encourage the participants to be thinking about the questions that are of greatest interest to them so that we can direct our conversation accordingly. First, I want to welcome Usama Bilal, who's an assistant professor of epidemiology and biostatistics at Dornsife and the Urban Health Collaborative. His research compares cities across North and South America using descriptive visualizations and data science to provide insights into why cities vary in disease burden and life expectancy. Welcome, Usama.
Thank you, Gina.
Second, Jen Kolker is clinical professor in the Department of Health Management and Policy and Associate Dean for Public Health Practice. She's engaged in policymaker and community engagement within Philadelphia and across the US, including ongoing policy surveillance and a new partnership with the Big Cities Health Coalition. Thus, she's especially well poised to help us think about how cities are acting to protect health of their populations at this historic moment. Welcome, Jen.
Thank you, Gina.
So our aim is to keep this session both informative and informal, and we're going to start by hearing some prepared thoughts to kind of set the frame on the role of cities, inequities within cities, and cities as they've been responding. And so I'd like to first give Usama an opportunity to tell us what you'd like us to have in mind as we get started.
Thank you, Gina. So I think it's important that we zoom out and we take a macro view on the role of cities in this pandemic, and that I think is key, and it's key that we continue doing that. First of all, we know that the pandemic originated in a city of around 11 million people, 19 million people if you consider its metropolitan area. So that's essentially the size of New York City's metropolitan area. Cities, as Gina said, are the place of increased opportunities for social contacts, and these offer opportunities for good things such as jobs, innovation, and wealth creation. But they also offer opportunities for the negative things such as increased pollution, crime, and the spread of infectious diseases. We know that once the epidemic started, it has spread through the international travel network. I don't think it's any coincidence that the top 4 countries by number of deaths, which are right now the US, Spain, Italy, and France, are among the top 5 most visited countries by tourists, with the 5th country being China. We should also not forget that a good chunk of our travel is done by business people. For example, recent genetic evidence published in PNAS has shown that the first case in Mexico was a traveler coming from a conference in Italy, where the first case contracted the virus in a business trip to Munich, Germany. And this person in Munich was infected from another business traveler that had just arrived from Wuhan in China, the origin of the epidemic. We want to visit cities, we move to cities to work in them, we enjoy them, but there are also consequences to all of this activity. We need to find a balance and try to capitalize on the good aspects while minimizing on the negative aspects. Second aspect I want to highlight is what happens inside cities. We know from decades of research that the way our society is arranged, segregating people into social classes, racializing them, affording a given legal status to some of them, but not others, has consequences to our health. This is what we call the social determinants of health, and they are a very strong force that shapes population health. They cause a higher prevalence of almost every imaginable chronic disease in people of color, in poor people, in undocumented migrants, and in people that do not conform to heteronormativity. The first clinical reports from COVID-19 were very, very clear in that people with chronic conditions were much more vulnerable to suffering severe forms of the disease, and they will require hospitalization, mechanical ventilation, and intensive care, and eventually die. From that moment on, we should have been alarmed and expecting that the consequences of COVID-19 were going to be unequally distributed. And that's what we are clearly seeing. From testing per capita being much lower in poorer neighborhoods or segregated neighborhoods of Philadelphia, to the actual incidence of the disease being much higher in the most deprived neighborhoods in New York City. These are neighborhoods that concentrate poverty, overcrowding, lack of health insurance, and are the results of centuries of racism and classism. Health disparities have always been there, let's not get that wrong, but in crises such as this one, they become very glaring and obvious. And last, I want to take a broader view, going back to the zooming out, to the macro view, and think about what we can learn from cities elsewhere. The experience in Bergamo, Italy, in Milan, in Madrid and Barcelona in Spain can be highly valuable. But likewise, with Seoul and Munich has really good examples of how to manage this, and even the alternative approaches of Stockholm and Amsterdam. All these cities adopted radically different strategies, and to understand what worked and what didn't and what can be done is crucial for public health. This will be crucial for cities in the global south too, where testing availability is lower, health systems have a much lower capacity, the population has a higher burden of chronic diseases, and the social safety net struggles in usual circumstances, let alone in this type of crisis. So what happens in Mexico City, in Sao Paulo, or in the small cities of Guatemala ends up reverberating throughout the entire world. In summary, this pandemic has reminded us of the many issues that challenge the people's health, from the widespread health inequalities that have become even more evident through the role of globalization in the spread of wealth, inequality, and epidemics, to the importance of strong public health systems that can intervene when needed. Public health and urban health are definitely clearly one. Thank you.
Thank you so much. And I know that these observations that you've had about differences across cities and the inequalities within cities have been a lot of great interest to the media. And so it'll be wonderful to hear more about those interactions. But first, I want to give a chance for Jen to speak about what's facing cities. And I think your contact ongoing with the local health departments in Philly and elsewhere has been really interesting to put you in a position to understand what cities are facing at this time and what they're expecting going forward.
Great. Thanks, Gina. Thanks, Usama. That was terrific. So much of the discussion about our response to COVID-19, particularly in the US, is really focused on the federal government and state activity. Today, I'm going to discuss more of the public health response at the local level, since so many of the people affected by COVID, as we've just heard from Usama, live in cities. 1 in 5 Americans, nearly 62 million people, live in an urban area, which is has a local city health department. So these cities, their mayors, following the public health advice from those health departments, are at the forefront of managing COVID-19. Leadership of cities has been evident from the beginning of the epidemic. Health departments were engaged in initial case identification, tracking, and contact tracing, and confirmed cases were still relatively few. And we saw mayors and health commissioners in Seattle and the San Francisco area really ahead of the pack by a few weeks in recognizing these epidemics in their cities. Cities have led on establishing testing sites, ongoing surveillance, and other public health measures. As cases grew, it was often first cities that had to make decisions about canceling of parades, social distancing, closing of businesses, and the many strategies that we have in place today to protect public health. And it's really important to note that while all of this was incredibly necessary for public health, the recognition of poverty, of social and health disparities, of city residents' reliance on a health and social safety net in cities made these decisions incredibly painful for city leaders. For many cities, these decisions were made just ahead of or in collaboration with their state governments. But for some, the public health actions that they took or tried to take were in direct conflict with their states. And as states are now beginning to talk about opening things back up, that dynamic is playing out as well. Just yesterday, the governor of Georgia ordered some businesses to open this week. On Friday, issued an order that some businesses are ready to open. And in that order, he specifically prohibited any localities or any cities from imposing anything more restrictive on the state. So the city of Atlanta will see their gyms and hair salons and other businesses open, regardless of what they believe to be in the best interest of their health in their city. And this is likely going to play out in other states and cities over the next several weeks, in those states where city and state have divergent beliefs and interests in public health. So many people are talking about, well, what happens now? And what are cities thinking now? And what are localities thinking now? So in terms of the pandemic itself, most cities are still managing every day, day to day, collecting case information and managing their healthcare systems, but are now also starting in the planning stages for a next phase. Once cases are consistently on a downward trend and are at a low enough daily number to begin to shift the approach. So first, like everywhere, cities will need to ramp up testing. They need to ramp up case investigation and contact tracing. Testing largely depends on availability of tests and lab capacity. And cities are planning for building of staff capacity for contact tracing. There's been a lot written in recent days about contact tracing brigades, and city health departments are making plans to greatly increase their capacity by hiring new staff, using public health students, and building on volunteer networks. Cities are also making plans for the gradual easing of social distancing and figuring out exactly what that means. Do we reduce restaurant capacity by 50% and require the wearing of masks except when you're eating? Do we reduce the availability of public transportation, and what does that do to the density within a subway car? So cities are having to figure out all of those different aspects of what gradually lifting social distancing might mean. They have to figure out what to do about the provision of city services, and they need to monitor and enforce whatever rules are in place. Even with social distancing being eased somewhat as we get to a different place in the epidemic, cities will have to continue to protect the most vulnerable. People living in congregate settings, so nursing homes, behavioral health facilities, jails, homeless shelters, and seniors living at home. And finally, there needs to be daily analysis of case data so that if there is a spike in cases, cities can act quickly and reinstitute certain restrictive measures to protect the public health. The good news in all of this is that these are actions that city health departments know how to do. These are basic public health actions in terms of disease control. They need the resources to do it. They need the money, they need staffing, they need testing, but this is what health departments do and have been doing for 100 years. This may be a novel virus, but most of the public health actions needed to manage it are not new. Beyond the management of COVID itself, cities are facing an unprecedented blow to their economies. Cities are relying on taxes from sales, businesses, tourism, entertainment to fund basic city services. Almost all US cities are rethinking budgets and expecting major cuts to services, right at a time where there will likely be increased demand for services because of the economic hardship so many city residents are facing. Beyond city governments, health, transportation, and school systems are also facing horrible budget cuts. Many cities were just recently seeing strong recoveries from the 2008 recession, and this will put them back significantly. This will not be a quick recovery. In the longer term, the great unknown question, something Usama alluded to as well, is what will extended social distancing do to the social fabric of cities? If cities are built on the premise of population density, robust public transit systems, arts, culture, and busy social networks, how will that change if we're faced with 1 to 2 years of some kind of social distancing? Will the allure of cities fade for those who have the ability to move somewhere else? On a more positive note, COVID has forced a greater awareness of what public health is and what city health departments do, as well as the role of social inequities and determinants of health. City residents are learning that urban public schools are safety nets for food and shelter and not just for education. Pollution is down, philanthropic giving and volunteerism is up. So while COVID may have many unknown and potentially negative impacts on cities, we may also see some positive effects as well.
Thank you so much. There's a lot of ground for us to cover in thinking about what it is that is leading to this current situation and what the consequences will be for us down the line. I think it's a good moment to go to a question that's come in through our Q&A from Leon Vinci. Data and recent reports show that NYC COVID-19 experience links to French and German origins, not necessarily from Italy or China. Any further comments about the strains and their reach? And I guess to maybe just add to that, we've been distinguishing between the SARS virus, SARS-2 COVID virus, from the COVID-19 sort of syndrome of symptoms. So I guess this is really about the organism itself, the virus and the strains of it. Is there something that Usama, maybe you can comment about what we understand about the origins?
Yeah, sure. Before doing that, let me just do a very brief summary of how we know these kind of things. So one really interesting tool that we have at our disposal is that we can sequence the genetic code of the virus. Now that virus, as it moves, infects other people, it mutates a little tiny bit. So by following those mutations, we can track where the virus comes from and where it goes, and then we can say this virus started here, then it went there, then it went there, and then it went there, and the version of it that, for example, ended up in Mexico came from Italy, and the Italian one came from Munich, and the Munich one came from China, like that kind of thing that I mentioned before. And I also want to highlight how important this kind of analysis are and how important the international collaboration is for these kind of things, because these analyses are happening because a lot of scientists are sequencing the virus, are uploading them to collaborative networks where they do this kind of analysis. This wouldn't be possible in a world where the US does its own kind of science, China does its own kind of science, Germany does its own kind of science. We all need to collaborate on this, and all of this genetic sequencing is a great example of all of this. Now, we've done this in a few months, which is impressive, the way we've done this. And I think it should be really a testament to how science can work really, really well. And this wouldn't be possible without research funding. So another reason why research funding is important. So now to the question itself, this can provide us with clues of how the virus moved and where it came from, and especially at the beginning of the epidemic, where it is unclear when the virus arrived to a specific area. It is very important to know that, for example, in the case of New York, it seems that some of the strains went there from, if I remember well, France and what was the other one? Germany. Which, by the way, is similar to how it got to one of the other epicenters of the epidemic, which is Spain. Now, what you need to ask yourself here is, with this kind of information, what does it tell us about how the virus moves? It tells us that the virus moves through all of these air travel network, because some of the most common travelers to the US from Europe actually come from those countries. So that is important for the purposes of understanding how the virus moves, but it's important for future prevention effort, because if we understand that the virus is moving through those travel networks, addressing those issues in the future will also be important. And that's, for example, what China is doing now that they brought the case count down, but most of the cases that they're having now are coming from the outside. So that's another important aspect there.
Thank you so much. I wonder if it's useful to look at not only the spread of the virus, but the spread of ideas about how to respond. And I wonder if, Jen, maybe you could speak to how some of the approaches to social distancing or to other protections, for example, protections against eviction, your sense of how that information, those ideas are spreading across cities.
Sure. I mean, I think some of the basic kind of pure public health things have been pretty much across the board. So social distancing and reduction of crowds. I mean, it's kind of crazy to think that one of the early things that people were grappling with, and when I say early, it was only about a month ago, was whether or not to cancel St. Patrick's Day parades, which now the idea of having a major parade in a major city seems unthinkable. Some have said that if the San Francisco had won the Super Bowl, we would have seen more deaths because there would have been a city parade there when the virus was likely circulating. So I think we've seen in quick progression, most cities adopting the same type of social distancing and pure public health responses. Things like creating a stronger social safety net. So minimum wage legislation, prevention of evictions, and other things to kind of help cities and help residents of cities not bear as hard of a brunt of these economic shutdowns is something that a bunch of different people are starting to look at. So there's a policy tracker that Bloomberg Philanthropies has started where people are actually just self-reporting different things that they're doing. There's a policy surveillance project out of Temple University School of Law that's looking at some of that. And here at the School of Public Health, at Dornsife and Urban Health Collaborative, we're also starting to look at what some of the different policy initiatives are in different cities to try and ameliorate some of the economic and social effects of the epidemic.
I know, Usama, you've been working with some data in cities across Latin America, as well as in with connections to Spain. Is there anything else you want to add about how ideas about how to react to this are spreading?
Well, I think Spain is an interesting case study because it's essentially if we ignore China as the thing where it all started and we focus on the countries after that, Italy and Spain were the two hardest hit countries by far, next to Iran too. So what the difference between them is only a week or two. So they are essentially trying to understand what they must do now without really many places to look at. So it's kind of a process of trying and then adding this and then trying the other thing. Is a little bit of trial and error. But I want to highlight how important it is to understand what the political structure of the country is. In the case of Spain, the national government can mandate a national lockdown, and that's it. It can do that. It did that on March 16th. It mandated everyone goes home unless you're working on an essential job. In March 18th, in March 20th, it said everyone goes home, like regardless of anything. Now, you cannot do that here from the federal government because you need to have the states do that. So that when we try to understand what is going on in the US, I think it's really important to understand that the political structure of the country creates very different challenges here. And I think all of the preemption things that Jen was mentioning are also key, because now cities in Georgia cannot say, no, we are continuing in lockdown. So those kind of complexities are key, but I think they are also opportunities, right? Because it's harder for the Spanish regions to say, no, we'll do this differently because the epidemic is on a different stage here, or we have this capacity that the other region doesn't have. While here states and to a degree cities can also do that. So it's a complicated balance there.
Can I just jump? I also want to jump into something Usama said, because I think, and more of these conversations I think happen very early on when people would say to me, why aren't we doing what China's doing? Why aren't we doing what Italy's doing? Why don't we just lock it all up, shut everybody down? And I had a lot of conversation at the time, which is that this is a very different country and we take our freedoms very seriously. And very often those freedoms, when you're in a public health emergency, feel indulgent, but we can't just switch on a dime. We can't say we're going to be a civil society and an open society and have states' rights and have individual liberties, except when we don't want to. And that makes things more complicated because of the political structure that we are in. And it's why some of these country by country comparisons, as Usama said, are tricky.
So since we've been already on the topic of preemption and we got a question, Jana Hirsch asks, which research groups, if any, are tracking preemption policies, like the example discussed in Georgia? And how likely is it that we'll see these actions across states in the United States context, I think?
So I can't say off the top of my head, other than the places I just mentioned, around which specific research groups. I mean, there's been a lot going on around preemption, mostly between states and cities, on a lot of issues over the last several years. More and more states are prohibiting certain cities from passing anti-LGBT discrimination laws, minimum wage laws. So there are a lot of areas in which preemption has become kind of a hotter issue between states and localities. This is just one more that we're seeing. It's possible that depending on what happens with this epidemic and how strong cities are, and we see some of the divergence between the epidemic at a state level and a city level, that may call into question some of these actions around preemption, and maybe we'll see a little bit more of a pushback in the other direction.
I think building on that, we can also think about this not only having a current context as we're looking at from one city to another, how the reaction is playing out, but also having a historic precedent. As Jen said, there's a lot in what we're doing that isn't new, and some in what we're experiencing that does echo previous models. And so we got a question submitted in advance that, as a possible model, studies that have analyzed the epi curves of several US cities during the Spanish flu pandemic show differing results. Although it's still very early, can you extrapolate that data to our experiences in this current episode? I don't know if Usama, if you want to help us with that.
Yeah, thank you. I think that's a very timely question, and I think that shows, the power of research in cities. Because if we hadn't done that kind of research, then I think encouraging those type of social distancing measures that we started around a month or even earlier than a month ago would have been much harder. And some of this research, what it showed is that the cities in the US that enacted or that intervened earlier had a lower mortality because they could spread all of that mortality curve. They could flatten the curve, and that's where the phrase essentially came from, through a much longer period, and then we'll end up with a much lower mortality. And we also need to be careful because as with the 1918 flu happened, there may also be second wave. So we need to be careful with that, and we need to be ready to act if it is needed. So and all of these pandemics, both the 1918 flu, the 1967 flu, I believe, the SARS, MERS, etc. All of those are learning experiences, and I think every time we bring what South Korea did to the conversation, which I think is one of the model countries, and we need to remember that South Korea had quite a few cases of SARS in 2003, and then had a large epidemic of MERS in 2015. So South Korea was already had a few of these happening, and in a sense, South Korea. I like saying that South Korea got a sort of social vaccine there, because society itself developed the defenses to act against future epidemics because it had a few of them before. So what I hope is that we do the same. We learn from this one to develop those kind of defenses against future epidemics of the same virus or other different viruses. So we need to learn from this one.
So one of the questions that's just come in, I think, is interesting in terms of how we learn from this situation going forward. There's a question, any thoughts on the public health implications of the staggered approaches that some states are adopting with relaxing social distancing? And what preparation mitigation tactics will US cities have to take to prevent potential backsliding? That things are happening in different times, I think, seems like both a challenge and an opportunity. We had a question about what's being done to track that for potential research, but any other thoughts? Maybe we should start with Jen on some of these actions being staggered.
It's like everyone else has said, it's really complicated. There are certainly, within every state, there are parts of the state that are harder hit than others. And there are parts of the state where you may say it is safe, whatever that means exactly, we don't entirely know, to let economies go back a little bit. I think here in Pennsylvania, Tom Wolf has said they're looking at some staggered approaches based on population, based on count numbers. Philadelphia will not be in that first wave because we're not there yet. So it probably makes some sense to do some staggered approaches. The tricky thing, of course, is that people don't stay within boundaries and the virus doesn't stay within boundaries. So if I live in Philadelphia and Berks County opens up its bars and restaurants and I decide I want to get in the car and go there because I'm tired of being in my house, well, what does that mean? Because then I'm driving home to Philadelphia the next day. So how that actually plays out and how it happens is going to be sort of interesting and tricky to watch.
And I should add that I think it's key that we have plans for going that way, but also plans for going back to social distancing. Yep. We need plans for both aspects of it, because it may happen. It may happen that we start going down in terms of social distancing. We open things and then we notice, oops, seems that we need to close again, and maybe not close entirely, maybe just close key things. So I think it's important that we identify aspects that will have high impact and that will prevent the highest amount of cases with the lowest impact to the economy in case that is needed, and that we develop protocols for knowing how to go down, but also how to go up again.
So you mentioned the situation that Philadelphia faces compared to elsewhere, and one of the questions that we got from Carla Campbell is how does the epidemic in Philadelphia compare to other cities in severity?
I will, if I
Or
may,
you
I
talk
will.
about the numbers, yeah.
Yes, I
Okay.
can talk about the numbers. I mean, obviously, New York is on its own league there. They were some of the first to be affected, probably shared that with Seattle, but they were clearly the hardest hit. You know, there are many factors, and we still don't know exactly what that was. Everyone else is kind of on a second wave. Now it seems that Philadelphia is numbers-wise next to other similar cities such as LA, such as Boston, etc., etc. It doesn't seem to be a clear outlier either way. You know, not being a clear outlier is a good thing because you could be doing very well, but you could also be doing very, very bad. So at least we are next to cities that are similar in size. And keep in mind, this is a city with high levels of poverty. So we are a especially vulnerable city. If the number of infections goes up a lot, we are especially susceptible because we have a lot of people that live in poverty, which we know increases the risk for chronic conditions, which we know increases the risk for having severe illness. So we really need to control this through public health before we overload the medical system.
Jen, did you have anything you wanted to add about what's
No,
distinct
just,
here?
you know, the health commissioner had said this week, you know, right now it's looking as if cases are starting to plateau, and which of course means hospitalizations and deaths will still follow. So those will still go up since cases are about 2 weeks ahead of hospitalizations and deaths. But they're still, I mean, we're still at about 400 or 500 a day. It's hard to look at the daily data because labs report in batches. So things are not getting worse. There's still hospital capacity in the region. Some individual hospitals may be near capacity and have to transfer, but we have not, as some said, we've not seen that deluge that New York had seen. Of course, the scary part in all of that is that every time people hear, oh, we're leveling off, all everybody wants to do is say, yay, we're done, and run outside and have it be over. And that's the greatest risk we are sort of all facing right now, is how do you, first of all, it needs to continue to lower, not just plateau. So 400 cases a day or 500 is still too high. And then how do we go back in a way that we don't just completely have a second spike?
Well, as we think about how to mitigate the effects of social distancing, right? So social distancing has potential benefits for slowing the spread and keeping our healthcare system from being overwhelmed, but also is affecting, of course, incomes, especially for vulnerable communities. Can you speak to what policies cities have undertaken to conserve economies and protect the livelihoods of their populations? And Jenna Hirsch, who submitted this, gave the example of eviction restrictions, that landlords aren't being allowed to evict this time.
Sure. I mean, eviction restrictions is probably one of the biggest, earliest ones, which of course has been incredibly important. Although it's also important to remember that some of these, you know, landlords are also having to pay their bills. And so this downstream, upstream effects of all of these policies have impacts on different areas, but that's been the big one. There's been an increase in a lot of philanthropic giving. So pretty much all cities have created some types of COVID relief funds, delaying in payment of taxes, payment of city taxes. So there have been a wide range of sort of economic policies, at least in the short term. Now, whether or not cities will be able to maintain those things over time, I mean, people are still going to be in dire straits economically in 6 months. City governments can't afford to let people not pay taxes, or they will have no revenue to provide city services. So at some point, there's going to be a gap between this initial sort of flood of trying to ameliorate the economic downsides to this and cities' ability to be able to perform basic city services.
And I should add that I think it's also important to consider how the impact of social policy, what the impact of social policies on the epidemic itself is. Because I don't think it's a coincidence that with the US being one of the few Western countries without mandated paid sick leave, one of the first things that was on the conversation as the epidemic started is we should have paid sick leave. Now, why was that in the conversation? Is because that's an essential tool to be able to control an infectious disease epidemic such as this one, so that people will stay at home if they are sick. So it is important that we consider that social policies downstream are health policies, and that they can be very, very helpful in controlling epidemics that end up affecting everyone else.
Yeah, I would add to that too. You know, one of the biggest issues in many cities, and particularly here in Philadelphia, was when public schools very quickly had to go to online learning. And then all of a sudden people said, oh, wait, not everybody has a computer. Oh, wait, not everybody has internet. I mean, people have known that for years. The fact that 15% of households in Philadelphia don't have access to internet was not a surprise to anyone. But when you're suddenly thrust into online learning. So like Usama said, there may be certain things out of this that we've been able to shine a light on in terms of social policy that could have implications for public health and the social fabric long-term.
I think that leads us well into this question we received about marginalized communities. So we were asked, what has been the response of marginalized communities to social distancing? And what role might longstanding distrust of public health among marginalized communities play in the responses to those social distancing requirements? And I know that Jen, you have some contact within Philadelphia to communities, and some I know you've been in contact with the media, so that it gives a different kind of exposure. So maybe we can start with Jen, but it'd be great to hear from you both on this.
Yeah, you know, I don't have a lot on differences in adherence to social distancing by marginalized communities. The city of Philadelphia did a survey a couple weeks ago and found that about 68% of people were adhering in some way. I haven't seen specific data on how that has varied, though certainly what you raised, people who have a fundamental distrust in government or in public health and in being told what to do are not going to want to do this. And people who are in positions where they can't do it because of economic reasons are not going to be able to socially distance. If we look at our essential workers, you know, the people who are working in grocery stores and the people who are delivering our food and delivering our Amazon deliveries are doing it because that's what they need to do. And so some of the social distancing adherence is based on attitude and some will be based on necessity.
I will add that also, I think some organizations, some nonprofits and some community organizations in some marginalized communities are trying to step up for what is not being done. For example, I know there is a couple organizations in Philadelphia doing testing in some neighborhoods. I believe there is a church and then a nonprofit organization that are trying to organize their own testing sites. So sometimes they are filling for let's say the gaps that are being left there. So that is also key.
One of the questions we just got from Dan Hardy is, what are the prospects for large-scale testing available to people who are not older or healthcare workers becoming widely available?
We're both laughing. I mean, right now in Philadelphia, if you are symptomatic, I mean, testing is still limited because there are not enough testing supplies and it's limited by lab capacity to turn tests around. But if you are symptomatic and you're a healthcare worker or you're over the ripe old age of 50, then you can get a test. But they do not have the ability yet for widespread testing. I forget what the different numbers are in terms of what you would have to be able to do per day in order to get us to a point of safe social distancing, but we're nowhere close.
I should add there that the Johns Hopkins Center for Health Security considers that we can only start relaxing social distancing at the state level once 4 conditions are met. One of them is that the number of new cases has declined for 14 days. Then that there is enough personal protective equipment for healthcare workers, but then that we have capacity to conduct contact tracing for all new cases, and that there is rapid diagnostic and testing capacity for everyone with symptoms, as well as close contacts and those in essential roles. So it's key that these capacities end up ramping up in order to be able to continue to start reopening states. So definitely having the capacity to do tracing and tests is key in this epidemic. And as I said before, it shouldn't be a shock, and I think it should be something that we should be communicating more often, that will go through kind of waves here. close, reopen, close, reopen, close, reopen. We may not need to close entirely as we did this first time, but that this is gonna be an iterative process. And during that process, we'll hopefully continue ramping up testing capacity, ramping up contact tracing. Hopefully each of the waves will be smaller and smaller so that it becomes easier and easier, etc. But this is an iterative process. This is not a once and done that will fix everything now.
I think you can imagine that some of the questions we're getting are about reopening the economies both in Pennsylvania and in the US. So just to kick off that discussion, in Pennsylvania, we got a question. The governor proposes a reopening strategy that's more restrained in Philadelphia than elsewhere. And given potential interactions between people in urban and rural areas, it makes sense to have a variable opening strategy in different parts of the state. And I will, also just sort of particularly prompt you on that urban-rural split, sort of what's special and different in cities, and where do we share challenges with rural areas?
Usama, you're muted. Should I start? Or do you want to start?
Yes, go ahead and start.
I'll start.
Yeah, sorry.
So I would say, I mean, I spoke about this a little bit earlier. It's tricky when you think about boundaries, obviously, because we can't just say, okay, COVID, stay here. But at the same time, it's clear that there are maybe areas in Pennsylvania that are at much lower risk or have fewer cases, that are far away from Philadelphia. My hunch is that it will be a regional approach, not simply the state and then Philadelphia. So my guess, I mean, remember that the first hotspot in Pennsylvania was Montgomery County. It was a suburban county outside of Philadelphia. So my guess is that there will be a southeastern Pennsylvania approach, which is the counties close to Pennsylvania, Bucks, Chester, Montgomery, Delaware, Philadelphia, and potentially up to the northeastern part of the state, so Lehigh County and the Lehigh Valley. So I'm guessing it will be much more regional, so you don't have this sort of, I'm going to cross the boundary there and I'm going to come back there. So you want to talk about some of the rural?
Yeah, and adding to that, it's also important to consider that there is a city across the river. So that's it.
Mm-hmm.
It's find ways of coordinating that, because it's cities. It may seem like cities do respect state boundaries, but places where people move don't respect state boundaries. So that's something that we also need to be careful with. With regards to what makes cities urban areas and rural areas different, a key thing is that in cities you are much more in contact with other people. Whatever you do, there's a much higher likelihood of you being in close contact with other people, which is probably one of the key reasons why people are in cities. So cities have the arts, cities have the sports, cities have theaters, cities have all of these things. Now, what we need to do is, I think what we need to do in the case of cities is identify what are these kind of activities that are higher risk, and maybe we can do in a different way. Now, in rural areas, while there may be a lower likelihood of contact, we also need to be mindful that there may also be a lower availability of healthcare services. So how does one in a rural area that is very remote get tested? So are we really getting a sense of the burden of disease in rural areas? That's something that we need to consider, right? And all of these decisions about reopening, closing again, reopening, closing again should be driven by this kind of data. And we need to be very careful that the data is collected in a way that represents both the cities and the rural areas, so that we identify whether the things are going well or not in both areas in similar ways. So that's something key. And also one thing there, which I think I mentioned before, is how the virus or the viral infection interacts with previous diseases. And we know that, especially in some rural areas of Pennsylvania, there's a higher prevalence of some chronic diseases. Mm-hmm. So we also need to be careful in those areas, because an infection in someone with a prevalent chronic condition may be much more harmful, which means we need to be extra careful there.
You may have touched on some of this, but I want to make sure Jerry Miller's question gets a chance for a response that just to asking Jen about the relationship between the state health departments and city or county health departments. If there's anything else you want to add about that.
So, I would just add, and I can really only speak to Pennsylvania. I think we were fortunate that we have a strong Pennsylvania health director and a strong governor, and a governor that listens to their public health director. In the same way that in the city, we have a mayor who listens to his health commissioner. So those have all been, I think, critical components in why Philadelphia and Pennsylvania have fared well. I think that the relationship between the two has been pretty good. From what I've seen, the relationships between the city and the state have been going well, and same with the different counties. I can't speak to, I spoke a little bit earlier about different states. That's not always the case. And it's not exclusively a red state, blue city issue, though it's largely that, but it's not exclusively that. We saw in Ohio, which has a Republican governor, taking immediate, very, very early steps and very much in step with the cities within that state. So I think we are at a good time in our history right now. My hope, and when I think about some of the positive things that have come out of this, is I think the level of collaboration, coordination, both between state and county, city health departments will be strengthened through this. And when we talk about reopening and looking at regional approaches, we've seen governors from the Northeast corridor getting together to have planned approaches. The governors in the West Coast are having a planned approach, governors in the Midwest. So there is a sense of recognition of interdependence in public health decision-making that I think we may see and learn from for next steps.
So I do want to recognize we have quite a few questions. So I think we'll try to move through several of the outstanding questions quickly. Some of them I think we may have already partly touched on. You've been mentioning some red state, blue state splits, and we got a question from Bridget Doherty about the urban-rural political divide in this country and the potential impact on policies in healthcare, and whether COVID and the public health approach, the ultimate outcomes of this situation, are ultimately going to be helping or hurting that divide.
Yeah, I think Bridget's one of my former students, so I feel really compelled to say something very smart. My hope in all of this, because I sort of lean optimistic, is that we will learn. We'll learn things and it will help. It will help a divide. I don't know that it will. And so, yeah, some of what we're seeing in terms of urban and rural, in terms of red state, blue state, in some of the southeastern states, and the rebellion and the pushback against government and infringement of rights, this is nothing new. COVID is just a perfect palette for it to be acted out on. And you don't want to wish bad things. You don't want to say, oh, well, people that went to a parade or a demonstration, the only way they'll get it or they'll understand it is if they get sick, because we don't want people to get sick. So, my hope is, like all things, we look back, as Usama said, and we learn from this. Whether or not it does anything in the sort of near future for these incredible divides that we have in this country politically, I don't know.
So turning to some of what's been articulated at the national level, we got a couple of questions from Leon Vinci about the U.S. President's 3-step recovery plan, and saying that it was actually very well done, and that no state is qualifying for the first level, I guess the first step towards recovery. And he's saying he agrees that there should not be a lessening of safety measures for any state or any part of a state until those parameters have been achieved. Do you want to say anything about the milestones for moving forward towards recovery?
Well, one thing I would like to say there is that any milestone that relies on public health data needs to acknowledge that right now, in our current state, that public health data is very imperfect. And we need to be careful in interpreting things like case numbers, like death numbers, all of these kind of things, or hospitalization numbers. We've seen it in New York recently when the number of deaths was changed, because now they are including suspected deaths. If you follow it in Philadelphia, and you see the days where the community testing site had to be closed because of the weather, you see that the case count goes down, etc., etc. So we need to be cognizant that up until we have a robust surveillance system that can have the yields of the numbers that this epidemic requires, which isn't a normal one, it's obviously an emergency one. Up until then, we need to be very careful interpreting these kind of numbers and interpreting trends. If you look for example, it's very useful again that we look at the experience of the countries that are a little bit farther in the epidemic, such as Italy and Spain. If you look at the numbers in Spain, it may look like the cases are going up again. What is happening is that testing capacity is going up. So what should they do? Should they close again because the numbers are going up again? Or should they start acknowledging that, well, testing capacity changed? So we need to be very, very careful with all of the numbers, and any plan with numbers should come with a plan to collect those numbers in a much more systematic way.
We have gotten a few questions that are not as specific to COVID-19 in cities, but I think are still very much on people's minds. And so I'll ask this pair of questions together. So Redolf Chalupa asks that since recent research seems to indicate 40 to 80% of COVID-19 cases are asymptomatic, how should this affect public policy? And I think also of interest in figuring out how to protect ourselves as individuals and city residents. Aisha Childs asks, is it possible to become reinfected after having COVID-19?
I'll take a little bit of that. Of the second question,
We don't know.
we don't know yet. I mean, there are reports of that, but we really don't know yet, and it is very, very unclear at this point. On the first one, we know there are a lot of asymptomatic cases. We're still quite unclear on the proportion of cases that come from those asymptomatic cases. Now, what is really, really important, I think, is recent discoveries that the infectiousness of someone that will be symptomatic is highest before becoming symptomatic. So let's say you acquire you are infected today. In 3 or 4 days, more or less, you will be at your most infected capacity. So you will be able to infect the highest amount of people. 2 days later, you will develop symptoms. So that's the problem there, that it is before you develop symptoms that you are the most infected. So what that means is that any measure that relies on just the surveillance of symptomatic cases may have missed a period of infectiousness. So we need to be careful with that, because then if we only tell things to people based on when they are sick, we'll miss the part where they were most infected there. So that's basic science discovery that is key in how we know that this disease transmits and in the prevention of it.
Another question that I think is particularly interesting that we just got in, is it just a matter of time before rural areas get hit just as hard? And they mentioned COVID-19 is more contagious than influenza, and influenza is not just primarily an urban phenomenon.
I think it largely depends. I mean, one would think yes. I think a lot will depend on what states do in terms of relaxing things and how social distancing gets lifted and how quickly we rush to do that, even in areas that seem to be low risk. But I think that is certainly a possibility and certainly a risk. Right now, we're seeing this largely in cities, but except in places, I mean, we are seeing it in certain industries, right? Meat packing plants in the Midwest. So we're seeing pockets of infection in rural areas where there are opportunities for population density.
Yeah. And I think especially in the most vulnerable rural areas, such as some native reservations in the West, where this has spread a lot, causing a lot of severe disease because of the especially vulnerable status of the population. So we also need to acknowledge that some rural populations are either older or have a higher prevalence of chronic disease, or both.
So we are coming near to the end of our time, and so I just want to mention a couple of the other challenges that people are raising. We did have a question from Aaron Borelli pointing to the potential for at the end of this experience, people to think that social distancing wasn't so necessary in the first place, which is kind of the general problem we have with prevention, that you don't know that you would have gotten
Right.
sick without the preventive actions. And then I think Ana Ortigosa has a question that I had kind of reserved because I thought you could fold it into your closing comments. What do you think the role of cities in infectious disease surveillance, from this pandemic and going forward will look like, and how's that connected with global measures, both I think on the data and research side, but also on measures of control and action that cities can take going preventively. I think with that, I'd like to give Usama and then Jen a chance to just make some final comments before we close out, realizing that there's much more that we could continue this conversation about. So Usama, what would you like to leave us with?
Okay, so thank you, Gina, and thank you to everyone for attending this webinar, for the wonderful questions. Thank you, Jen, too, for bringing all of your knowledge on how this actually works, how public health practice happens. And what I would like to say is that we don't know yet for how long we are going to be in this. We are knowing more and more, but we don't know yet. And we don't know yet whether we'll be able to relax some of these measures, and then we'll need to get some of them. We need to we'll need to enact all of these social distancing measures again, closing things. We don't know yet. Now, what is known is that classic public health works. I think Jen said that before. The classic tools of public health, all of the surveillance, contact tracing, et cetera, all of that works. What we need to do is use all of these periods of social distancing to improve on that capacity, so that the periods of social distancing are the shorter that they are needed. And when we open, or while we are closed, we need to see what sectors of the economy or the sectors of social life are key. And one of them that I would really like to emphasize, because I think we really need to make a big effort of this to work, is schools and education. Because schools and education have a huge impact on social inequalities, and we cannot let the crisis be yet another opportunity for social inequalities to widen. If we have public schools delivering a much less intense form of education through remote teaching than private schools are doing, we generate inequalities in education. If we have kids at home, we generate inequalities in who takes care of them and who can work at that time. And also we generate gender inequalities, because we have seen, and I've seen reports on the media, that in the case of academic productivity, they have seen that the number of academic manuscripts submitted by women in the last month has decreased a lot. We need to ask why this is happening. And if we keep schools closed, because we need to do it, then we better have a plan to at some point get that up and running again. So we need to develop priorities of what needs to be open and at what point, and what can be safely open. And then we need to have a plan to how do we close again in case that is needed. And that, as I said before, will require data, will require a lot of public health data. So we need a good infrastructure to collect that data, and we need a strong public health departments to take care of that.
Thank you. I think with that, let's give the last word to Jen, and then I'll have just a closing comment quickly.
My family is laughing that I get the last word in. So, I feel a need to end a little bit on a positive note and sort of what we can do. And I think there's obviously a lot of uncertainty that lies ahead, both in the course of this pandemic and the near and long-term implications for cities. And there's a lot of work to be done in the short and the medium term, as Usama talked about, to get us through this crisis and to think about public health and how we manage these things. And it's going to be a long haul. And I think that's very overwhelming for the public and for those of us who are in this day to day. But I also believe that cities have a remarkable history of resilience and regeneration. And taking the long view, cities have rebuilt after wars, pandemics, depressions, recessions, natural disasters, and more sort of mundane challenges. So while there's definitely hardship ahead, health, economic, cultural, social, I think cities have it in their nature to come back, to muddle through and to survive. And we may look different. We will definitely look different in 2 years. We may look different in 5 years. And when our children are reading about this in their children's history books, we may look different again. But I think cities just gravitate toward survival. And I think we're going to come through this okay.
Well, I want to thank both of you and all of those who submitted questions to enliven this conversation. It's not easy to step into a rapidly changing environment and help us, guide our thoughts and come together around a cautious but optimistic view of what's next. I do want to welcome everyone to join for the next seminar, which is coming up on April 23rd at 4 p.m., entitled "Where Will We Go After Coronavirus? Opportunities to Strengthen an Overwhelmed Public Health Safety Net," as well as the Urban Health Collaborative is hosting an invited speaker event this Friday. You can learn more about these events by going to drexel.edu/Dornsife or drexel.edu/UHC. And I hope everyone stays well. Thank you for joining this conversation.
Thank you, Gina. Thank you, Usama.
Thank you.
Bye, everybody.
Thank you, everyone. Bye.